Oh,
Yeah, there's some good pictures in the book too. Not all of them are from here from the book, but some of them are from wonderful Google. It's interesting what you're able to Google. You know, like I would think there would be some kind of like block or something.
Right.
No, my browser history is all kinds of crazy. Let me just tell you. If anyone ever were to look at it,
what is this person
just looking up all this stuff. All right. Here's the list of topics today. Reproductive is a little bit more involved just because there's male and female and they're both different, right? And then there's also pregnancy as well. So there's kind of multiple avenues for the reproductive system. So we'll just try to get through as much as we can. I'm not going to go over the anatomy with you guys in class. You guys can look over that on your own. I just put it in there for your own reference just because it's going to take too long to do that. All right. Starting with STDs or STIs, you might see it either way: sexually transmitted diseases, sexually transmitted infections. So these are the risk factors. I mean, most of you know this from high school sex ed, but we're going to go over it again. Having sex with anyone that you don't know their history, so like if they haven't been tested, right? It's a good idea to get tested if you don't know what they have, who they've been with. The earlier you start out, too, the more at risk you are for sexually transmitted diseases. Any drug use with sexually transmitted diseases as well. Having multiple partners. Obviously, if someone has an STD and you have sex with them, that's a risk factor for getting an STD. Pretty common sense. Exposure with skin-to-skin contact. So if someone has, an outbreak of herpes or whatever, and you have skin-to-skin contact with them while they're having an active outbreak, and then not having education about it. So you're welcome for providing that to you. I'm decreasing your risk. Or lack of concern. So just kind of risky behavior, not using protection. The end. All right, cool. First one we're going to talk about is chlamydia. You've probably heard of it. Chlamydia is a bacterial infection. Okay, so not all the STIs are bacterial, but several of them are. Some of them are viral. Some of them are fungal or protozoal or whatever. The bacteria is called Chlamydia trachomatis. That's where they get the name chlamydia from. It's actually the name of the bacteria itself. It's spread via the genitals, oral or rectum, or even can be passed to the newborn in birth, right? Because the newborn passes through the vaginal canal. So if a mother has an active STI, they'll probably want to do either a C-section to avoid that or treat the mother before birth so that doesn't get passed to the newborn, okay? You can imagine passing on something like that to a newborn is very risky for the child because they don't have a great immune system yet. Chlamydia is one of the harder ones to diagnose just because in women they call it the silent STD. Like most women don't realize they have it. So there's generally not many symptoms with women. Men do tend to have symptoms within about 3 weeks of being exposed, just thin, watery discharge, okay? It might be burning and itching as well. Dysuria, what's dysuria mean?
Bloody.
Not bloody, that's heme, right? Heme means bloody, but it is about urine because it has urea. Dys always means pain or difficulty, okay? Like dysphagia, difficulty or pain with swallowing, right? Dysuria, difficulty or pain with urination, okay? An enlarged scrotum, so like from the swelling, fever, the swollen inguinal lymph nodes. Where are the inguinal lymph nodes?
Like in the pelvic area.
Yeah, remember the inguinal hernia we talked about in digestive? So the inguinal is like in the groin area. Wow. So lymph nodes in the groin area. So when you get a sore throat, your lymph nodes are kind of swollen in in your neck. It's kind of the same idea. When you have an infection, lymph nodes can be swollen down there as well. For diagnostic wise, they can do urine, vaginal, rectal swabs. You go in, you get tested, they can swab the secretions and look for, what they're looking for is presence of that bacterial DNA. If it comes back, no chlamydia, then you don't have it. If it comes back with it, then you do. And then since it is a bacteria, we're going to give antibiotics, right? So these are antibiotics. We should be able to recognize them because they end with mycin. Antibiotics end with mycin, and then cycline, doxycycline is a drug class, or tetracyclines are a drug class. And then since it's just an infection prognosis, it's acute, right? The only issue with chlamydia is that since it is mostly asymptomatic in women might have it for years not realizing that they have it, especially if they don't ever get tested, and it can cause sterility, not able to have kids if it's not treated. And passed on to the baby, it could cause blindness as well. So that's why they always do screening with every pregnant woman that comes in case they haven't been screened, right? Any questions on that one? Just shout out if you do. Next one's gonorrhea. This one's also bacteria, and the name of the bacteria is Neisseria gonorrhoeae. So you'll notice a lot of the times the diseases are named after the name of the bacteria to make it easy to remember. This is also spread via vaginal, anal, or oral contact, and it also can spread to the newborn at birth as well. So very similar to chlamydia so far. Symptoms, dysuria, again, so painful urination. Purulent genital drainage. What's purulent mean? What did you say, Jeanette? Pussy, right? So whenever you have drainage, it can be clear, right? It can be bloody, or it can be like that yellow, whitish, infected kind of pus. That's what purulent means. If you don't know that, write it down in your notes. The other thing with gonorrhea as well is that some of these, like, not everybody has symptoms, right? So some of them are asymptomatic as well. Diagnosis is going to be the same kind of thing. It's going to be swabs. They can swab the cervix, the rectum, the throat. So you can actually get gonorrhea in your mouth, right, if you're participating in oral sex, right? That's how you get that. And then treatment, it is a bacteria, so we got some more antibiotics. Ceftriaxone and azithromycin, they end in mycin. What drug class, who remembers what drug class ceftriaxone is? Starts with Ceph, what does that tell you? What kind of antibiotic starts with Ceph?
I don't know.
Cephalosporins. Cephalosporins is a drug class of antibiotics. There's several. I put them again at the end of this PowerPoint. We did them back in integumentary, so it's been a minute. You will need to know the drug classes and things for the final, so don't think that you can just throw them out your brain after the end of each exam. Easy to remember, cephalosporins, they start with Ceph. So cephalexin, ceftriaxone. And again, it's an acute infection. We treat it, it goes away. All right, next one is trichomoniasis. This one is not bacterial. This one is a protozoa, okay? And it is caused by the Trichomonas vaginalis protozoa. It's also spread via sexual contact. Again, symptoms a lot of times are asymptomatic. This is why getting testing is important. You might think, oh, I'm fine, I don't have any symptoms. That doesn't mean you don't have anything, right? Especially if you're a woman. Women tend to be more asymptomatic than men. Urethritis, that's just inflammation of the urethra, so it might be kind of difficult or hard to initiate urination. Painful urination, itching. These are kind of more stereotypical symptoms for men and women. So women tend to have more frothy green or yellow discharge, and men tend to have more thin white discharge. It doesn't mean that you could have something else, but that's just more like the stereotype. All right, the one thing that's different about trichomoniasis is that when you look at the cervix, we know that scopy is like a camera, right? Scopy, like they use an endoscopy, looking in the stomach, right? Anything that ends with scopy is a camera looking at something. So the colposcopy is what they do when they look at the cervix. So colposcopy procedure used to examine the cervix under magnification. So it's this little guy, they're looking at the cervix. With trichomoniasis, it looks like a strawberry, so they call it a strawberry cervix. This is a diagnostic sign for women, what it might look like under inspection. And then these guys are what the protozoa look like. These tiny little things under the microscope. That's what that looks like there. Okay, yeah, they can take a swab of that discharge, swab it, and that's what you'll see in the secretions under the microscope there.
I have a question.
Yeah.
You probably don't know, but maybe in your studies, do they know why women are like asymptomatic mostly?
I don't know. Yeah, it's just kind of one of those weird things. Some people have more symptoms than others. Like every person with the same disease is gonna look slightly different. I'm not sure why women tend to be more asymptomatic than men. Like, why do women have more likelihood of autoimmune diseases over men? I don't know. It's just one of those things. All right, treatment-wise, metronidazole, tinidazole. These are anti-protozoans, okay? The important thing with this one is that you can't have alcohol with these kind of drugs because they don't mix well. I don't know if you've ever been on any kind of medications. The pharmacist is like, don't take this with alcohol. Or you've seen like 1,000 Ways to Die. People mix it. Yeah. So there you go. All Alright, I'm sure everyone's probably heard of this one, genital herpes. There's actually another kind of herpes as well. There's herpes type 1 and herpes type 2. We're only talking about herpes type 2 right now because that's the sexually transmitted kind. Herpes type 1, you might see people with like, the cold sores or like lesions on like anywhere else in their body. There's often like breakouts of herpes in like wrestling, because people are doing a lot of like physical contact and like a lot of like sweaty, not clean mats and not clean, like the spandex and everything. So those aren't sexually transmitted, they're just from contact, right? So the genital herpes is the sexually transmitted kind, herpes type 2, just in case you're, because people asked me that before, like, what about like the oral cold sores? Like those are technically herpes as well, but not the sexually transmitted kind. Anyway, so herpes is a virus. This is not a bacteria, so we couldn't treat this with antibiotics, right? People can have the virus living inside their body and not realize it, and they can be passing it along. We call them shedders, right? They don't have any outward symptoms. And we know that viruses can't be cured, right? So once you have a virus, some of them stay with you forever. Like herpes is one of those. So when you do have an outbreak, they are blister-like lesions, typically anywhere in the genitals or anus. You may also have some flu-like symptoms on the first outbreak. There is no cure for these, unfortunately, and they're kind of with with autoimmune disease, people have triggers that have episodes like flare-ups. It's kind of the same idea. So you don't always have like a visible herpes outbreak, right? Like they come and go. So sometimes people get stressed, they have an outbreak, or they get sick, they have an outbreak. So it's kind of they're intermittent, so they're not always present. So this would be an example of when, like, if someone has an active outbreak, you don't want to engage in sexual contact with them because that's how they can spread it. They're usually considered safe when they don't have an active outbreak, but sometimes you can shed the virus, up for a few days before an active outbreak. So it's just wise to use protection anyways. This is what they look like. They're just kind of blistery like that. They can be, like I said, anywhere in the genital region. What kind of drugs can we use to treat viruses? Drugs that end in what? Vir, right? Because vir for virus. So you don't even have to memorize the individual drug names. You just see they end in vir. That tells you it's an antiviral, right? Acyclovir, famciclovir, valacyclovir. And we use these for all sorts of viral infections, not just herpes. So if you see like, oh, someone's taking acyclovir, that doesn't mean they have herpes. It means they have some kind of virus, right? Any questions about herpes?
Gross.
Yeah, I know, it's a super fun conversation to have. Next one is genital warts. Genital warts is caused by a virus, actually. The HPV, human papillomavirus. Anybody heard of the HPV vaccine?
Yeah.
Yeah, that's what the vaccine is preventing against, actually preventing against contracting HPV. So genital warts can go anywhere in the genitals, mouth, throat. And the real issue with HPV isn't just that it can cause the warts and everything, but some of the strands, there's multiple different strands of HPV, there's like a bunch of them, but some of them are considered carcinogenic, meaning that they can give you cancer, right? So like cervical cancer is the big one that HPV, the vaccine is like supposed to protect against, especially for women. So women tend to be more susceptible to HPV, and when they get it, if they get one of those cancerous strands of HPV, it can give them cervical cancer, okay? The genital warts themselves, they don't hurt. They just look like growths, right? Like a regular wart, but they're just in the genital area. Here's a picture of what some of them look like. They kind of look like these cauliflowery growths. Diagnosis-wise, I mean, you really just kind of look at it. You can see it. You can do a biopsy if you're like concerned that you don't know what kind of growth it is. You're like, is this a cancerous growth? Is this what's happening here? But usually you can go off of appearance, especially if they're in the genital region. There's only really one option of what it could be. Sometimes the warts come and go without treatment, kind of like with the herpes outbreaks where something triggers them, they flare up. But that doesn't mean that the virus is gone. It's still in your body, right? You can freeze off the warts. We call that what? Cryosurgery, or we can burn them off, which is cauterization. Yeah, that's also you also can call it electrodesiccation. Is kind of like the laser, which is the same kind of thing, laser burning. So if you see any of those things, that's what's happening. There is also antiviral creams that you can rub on there. But just because you've removed the wart doesn't mean that you've been cured, right? That you're still going to have breakouts. You're still going to have more happen, right? Because that virus is still in your body. So this is a like chronic thing you're going to have to deal with, right? All right. Next one we have is syphilis. This one is a bacteria. It is called. This one is actually not named after the name of a bacteria. So this one's called Treponema pallidum is the name of the bacteria that causes syphilis. What's different about syphilis is that they cause these things called chancres. They look like. Do I have a picture? Yeah. So it's kind of like this. Looks like almost like a. You know when you skin your knee real bad. You know, it kind of looks like that. It's like the first layer of skin is missing. I don't know if you ever did gym, like PE, and like you skid your knee on the gym floor and like your knee looks like the
carpet.
It hurt, yeah, carpet burn. It just hurt so bad. These actually don't hurt. So it looks like that, but they are painless. Okay, so it's kind of weird. Like it looks like it should hurt, but it doesn't. Yeah, those are called chancres. They're very contagious. They also can be spread in utero to the fetus, which is very bad, right? So like before you even like give birth, it can pass to the baby like while you're still pregnant. The other thing that's different about syphilis is that there's 4 stages of syphilis. Stage 1 is where you have those painless, contagious lesions on the genitalia, those chancre sores pop up. Stage 2 is where you start having more body-wide symptoms like fever, headaches, sores in the mouth, feet and hands. I think I have a picture of that. Yeah, so you can see like this weird rash and sores on the palms of the hands and the soles of the feet. That's very, very classic for like syphilis, okay? Not many diseases give you rashes on the palms of the hand and soles of the feet. Like hardly any do. Like palms of the hands and soles of the feet are usually not people don't get rashes there usually. Even with like skin diseases. So this is a pretty obviously like, oh, that's syphilis, okay? And then stage 3, people might think, oh, well, I got better, it's all gone now, because that's the asymptomatic stage where everything kind of starts to go away, and they think, oh, well, I'm cured, I guess I'm good now. But that's bad because what's happening essentially is that the bacteria is moving from the surface of the body and moving deeper into the body. Okay, so now in stage 4, now these lesions are all over the inside and the internal organs, and at this point it's life-threatening and pretty much fatal at this point. The good side of this is that it's just a normal bacterial infection. If you get it treated early on, you're perfectly fine, just like any other bacterial infection. So it only becomes life-threatening and fatal once it's in its final stages and it has been ignored. Okay, this is what the bacterium looks like. It's like kind of like a screw shaped, and that's how it's spiraling into the body. Okay, so it's like most bacteria are like, just round. You've seen like, just round little single cell bacteriums. These are actually corkscrew shaped, and that's how they're burrowing into the body. They can burrow into the uterus where the baby is and infect the babies as well. So that's how that happens. They also have a very specific diagnostic test. It's called the RPR blood test, rapid plasminogen reagent. This is only for syphilis, okay? This is the very specific test just for syphilis. They're looking for antibodies to that bacteria. They can also do a smear, just like they do for the other ones. Take a swab of the discharge and, put it under the microscope, and they can see these guys, which are very, very obviously syphilis. It's very hard to confuse that for something else. Treatment, bacteria, so antibiotics, penicillin, very, very common antibiotic. And then, prognosis-wise, it's fine if you get treated early, but fatal if not. Any questions on syphilis? I mean, they're all not pleasant. I think that's... Oh yeah, so this is bad. This is a drawing, not a real picture, so you're welcome, of how it can start burrowing into like the brain, burrowing into the face.
That can happen to people?
Crazy.
Yeah, if you Google images, advanced syphilis, I'm gonna let you look that up. not pretty. I decided to throw in a drawing for you guys instead of the real
Thank
thing,
you.
just to give you the idea.
Who's walking around like that?
Well, I mean, back in the day before they invented, before the invention of penicillin,
Yeah.
and people, were honestly still having sex, so
Yeah.
there's lots of like old records from like back in the day of like photographs, people with really advanced syphilis, and it's just really sad. All right, now we're going on to the male. We're gonna start with the male. First one is gonna be erectile dysfunction. Okay. Now, during sexual arousal, the veins, the vessels actually widen so that blood can rush to the area. Okay, that's where the erection comes from. It's all the blood rushing to the penis. Okay, so when someone has erectile dysfunction, they're having some issues with the vessels being able to dilate. Okay, so blood can't get there. Okay, and usually, not always, but usually this is related to lifestyle. So like as men get older and they have diabetes or hypertension or high cholesterol or obesity, like they're just not in great health, right? Erectile dysfunction is usually going to go hand in hand with that, right? Because with the cholesterol, they've got the plaque, inside their veins and arteries, so it restricts the blood flow, right? Yeah, so it can also prevent the blood flow down there. Obesity, hypertension, kind of all the same reason, it's preventing good circulation. Okay, so typically when someone comes into the doctor complaining of erectile dysfunction, that's usually like one of the first signs that they're not great with their circulatory system. Does that make sense? It's kind of like the first like warning sign that a doctor will see is like, oh, this guy, he's complaining of erectile dysfunction. That means he probably also has other issues too. But not always. Sometimes there can be medications that people are taking that cause erectile dysfunction, so it's not actually a lifestyle problem.
What are those medications?
You can look that up if you're concerned.
Oh my.
There can also be just issues with the nerves. So remember with neurogenic bladder and the urinary, like if there's trauma to the nerves, then like the nerve signals can't go to the bladder, right? And you can't make yourself pee. So same kind of thing. If you have any nerve issues down there, you won't be able to have an erection either. So that might not necessarily be due to lifestyle. And then there's also sometimes just like some psychological reasons where men can't have an erection, like they have some kind of sexual traumas or other mental things that like block them from allowing that to happen. So it's not always related to lifestyle, but it often goes hand in hand, especially if you see a patient, they've got diabetes, hypertension, cholesterol, obesity, anything like that, they tend to go hand in hand. Does that make sense?
Good man.
You okay, Amanda?
Yeah.
Okay.
I was gonna say something.
You can.
Mhm.
Okay.
Don't say it.
Oh, one of the thing I was thinking of, one of the nerve damages that can happen. We talked about prostate and urinary. They have like the prostate starts pinching on that urethra, and then they do the surgery to kind of like take out some of that prostate tissue. If in the surgery they damage some of the nerves, right, that can cause erectile dysfunction. So that's one of the common like ways that a nerve issue could happen.
I can sue them for that, right?
Oh.
That's
Yeah.
not a me question. Talk to a lawyer. So diagnostic wise, if someone comes in that's like their only complaint, they're probably going to do a full workup, right? Because like I said, if the doctor's like, this guy's coming in and he's 40 years old, he's complaining of erectile dysfunction, I bet you he also has cholesterol issues and hypertension, so they're probably going to also check that up to make sure. Looking at their lifestyle, how's their stress, alcohol, smoking, because all of those can contribute to erectile dysfunction. They're going to look at the list of any drugs they're taking, see if any of the drugs is causing it. So that's kind of, they just do it kind of trying to figure out what the cause is, right? Because erectile dysfunction is a symptom of something, right? So something's causing it. They're trying to figure out what. Treatment-wise, you've probably heard all the commercials about Viagra. I'm sure everybody's heard of that. Sildenafil is the brand name, the generic name, or tadalafil. They all end with fill. You can remember that, like the penis fills with blood. Okay, it's just a way to remember it. That's the most common ones: sildenafil, tadalafil, Viagra, and Cialis. And this is usually a chronic issue, right? Because it's usually related to lifestyle, right? That doesn't happen overnight. Now, it could be that they're just taking a medication, and that's a side effect, and they just stop taking stop taking that medication, and it goes away. But generally speaking, if it's due to like a lifestyle reason, it's going to be a chronic thing until they can get their circulation, blood pressure, diabetes under control. Okay. Do you have any questions, Makai?
So you gotta be healthy and you won't get this.
Correct. Eat your leafy greens, and do your exercise, and do cardio, and you should be fine.
Good to know. Good to know.
All right, next we got epididymitis, enzinitis, so it is inflammation of the epididymis, okay? That's going to be part of the anatomy. You can look at that when you get home. You can see where the epididymis is and what that's all about. Basically what the epididymis is, it's a location where sperm is stored, okay? So that's where sperm goes to be matured and where it's stored for long term. All right, so usually this is due to an infection, okay, so that's what's causing the inflammation. It doesn't always have to be though. Sometimes people have trauma, right? They get kicked in the nuts or whatever and it causes an inflammation down there. It could be also autoimmune, right? Just attacking itself, but usually it is caused by a sexually transmitted infection. Usually the same bacteria that causes gonorrhea or chlamydia also get up into the epididymis and cause the inflammation there. So that's the most common cause, right? So unless someone has like a clear history of autoimmune disorder or having reports of having some kind of trauma, like getting hit there, punched there, most likely it's going to be from sexually transmitted, right? So usually we're going to be treating that with antibiotics. Symptoms-wise, just a lot of pain in the scrotum, pain with ejaculation, and that makes sense because ejaculation is the releasing of sperm, right? And if the epididymis is what holds the sperm, then it would hurt to release that, okay? It could be also firm to the touch. Diagnostic-wise, they're gonna do, look at the urine. They're going to do a culture. Whenever someone says a culture, that just means, trying to figure out what bacteria it is, okay? They have those little red petri dishes where the bacteria grow and they can identify what it is. That's, it's a culture. They'll do a swab, look at the stuff under the microscope, see if they can identify what bacteria it is. Like I said, usually it's a sexually transmitted. They treat it with antibiotics and anti-inflammatories. Let's see, do I have a picture? Yeah, so here's the epididymis, and this is where the sperm is stored and it just inflamed. That's pretty much all. All right, next one we got is testicular torsion. This one is actually a medical emergency. Okay, so let me show you a picture first. Basically, you can see here that the testicle is just starting to spin and rotate inside the scrotum, which is bad because it starts to pinch off the circulation. Okay, if anybody ever sat on their foot for too long and their foot went numb, it's the same kind of idea. It's basically it feels like someone's wrapping up a rubber band around your finger and it starts turning blue. It's the same idea. It's spinning on itself and starts to block the circulation. The reason why this is a medical emergency is because it can die right from the lack of circulation, and obviously it's not life-threatening. You can live without a testicle, but it does potentially impact future fertility, not being able to necessarily have kids. You still have the other functioning testicle, but it just reduces the chances of fertility, right, because your sperm count's lower and what have you. So if someone has this, they need to go get it treated right away, have it untwisted, make sure it doesn't happen again. So it's people know that they have this. It's a very quick, sudden onset of very severe pain unilaterally, meaning only on one side. It's, I guess, theoretically possible, but I don't think anyone's ever really had both happen at the same time, right? So generally it's one testy that starts spinning at once. I actually had a friend who had this, and he said it was the worst pain he's ever felt in his life. He went immediately to the hospital, and he was like, I'm not playing around with this, right? And he got it fixed pretty quickly. So they do a pretty good job of getting it taken care of. How they diagnose it is they get an ultrasound, right, and they hold it to the testicle, and they can actually just literally see the lack of blood flow. They can see the twisting. They're going to take you in for immediate surgery. This isn't oh, hey, we're going to, talk about, scheduling an appointment a week from now. No, they're going to bring you in, for immediate surgery right then to make sure it doesn't die. And this is called an orchiopexy, where they basically, unravel it and then they stitch it in place so this doesn't happen again. Because they've noticed that once, it's done this before, it's likely to do it again. So they actually, stitch it in place so it's unable to have this happen. And that's that orchiopexy there. All right. Any questions about this one?
How do you avoid that?
there's really nothing.
Damn.
People don't really know why it happens. It's just kind of one of those weird things that just can occur.
My boyfriend, he was in the shower and he said the water was cold and then it happened. He had surgery that day.
I mean, that,
No more
Are
cold
you
water.
serious?
No more cold water. I got you.
Well,
right?
that does
In the
make
shower,
sense.
I guess
I see.
the water hit and I guess, when you struggle. He said
Yeah.
he just felt a terrible pain. And he said he was in high school, so he was embarrassed and tried to wait and didn't want to tell his grandma. He said he got to the hospital and he kept saying it was my stomach. Because he wanted like them.
Yeah.
Because he was in high school, but yeah. That's why I was like,
Oh, dang.
I mean, that actually makes sense because, they try to regulate a very specific temperature for the sperm to live, right? So that's why, like, they
That's crazy.
hang lower and go up in the, when it's cold to try to keep the temperature the same. So I guess that would, when it's lengthening or shriveling, like, you'd be more likely to spin. So actually,
He
that's,
just said he stepped in the shower and the water was just kind of cold and
Whoop.
it happened.
yep. Well, glad he's okay. Yeah, so it's not terribly uncommon, but it's not something that you can really do anything to prevent, unfortunately.
Yeah, and then my mom ex-husband, that happened to him and he actually lost it, so we couldn't.
Oh, wow.
So, yeah, that sucks. I mean, what was the other one not working?
Oh, I don't know all the details. I didn't know him, but she said she had already had us. But this was I was a baby when she got remarried.
That's funny.
He actually died. He died. I didn't even know.
Yeah, I wouldn't. That I
He didn't
guess
have kids,
you
so-
wouldn't know all the details about that. That's fair.
She said he didn't have kids, but that wasn't a problem because she already had us.
Yeah, I mean it can definitely impact fertility because some men already have lower sperm counts, right? And if you lose a testicle, then it's like even lower, right?
Yeah.
So it just makes it less likely.
Sucks.
All right, next one we got is prostatitis, so inflammation of the prostate. Okay, this is also again usually caused by an infection, again, but not always. The most common one is the Escherichia coli. You might have heard of the E. coli, and again, E. coli is the most common bacteria in the stool. So everyone has E. coli in their poop. Okay, that's why wiping the correct direction prevents feces from getting into holes it shouldn't be. Okay.
What's the correct direction?
Kai.
What the
Kai.
heck?
Do you need
Sorry.
me to demonstrate?
I'm like, what is the correct direction?
Through this chat.
Yes, ma'am. Yes, ma'am.
Hey, I'm happy to have you come up here and do the
I'm
lecture.
good.
Great. Okay, so symptoms wise, it's the prostate itself that's being inflamed, right? And so we know that the urethra goes right through the prostate, right? So you would imagine that you could have pain with urination, right? Because every time you urinate, it has to go right through the prostate, which is swollen and inflamed. Might have some pus also. That's also from like the infection itself. Maybe some low back pain and fever, just from the kidneys being in the back there. Hematuria, that's what you were getting at earlier, Amanda, the bloody urine. Diagnostic wise, they'll do a physical exam of the prostate, urinalysis, that's the UA, blood culture, ultrasound, kind of see, but basically once they get that culture, they know, okay, E. coli, we're going to treat with antibiotics, right? I don't know why these are so large. I don't know, okay. But these are also different types of antibiotics. The quinolone, we know quinolones, that's a drug class, everything ends in quinolone. And then sulfa drugs all start with sulf. That's how we can identify antibiotic names. And again, this is acute, treat it, should go away. That's the inflamed prostate there. You can see that it would be difficult to urinate through that when it's basically closed off, right? So usually men complain of like not being able to pee, so they might need a catheter to help drain the urine so they don't have a ruptured bladder type thing. All right, and then I mentioned this one last time in urinary, but we're focusing on it now since it's technically part of reproductive. So benign prostatic hypertrophy, benign just meaning what? What's benign mean?
Okay.
Correct. And then hypertrophy, what's hypertrophy? If you don't know, write this down because this is a common word in other parts of the body as well. So hyper means too little or too much.
Too much.
Too much, and then trophy has to do with growth. Okay, back in the heart, we talked about left ventricular hypertrophy, right? That was where the left ventricle is growing too big, right? So hyper meaning too much, trophy is growth. So why does this happen? I'm sure Makai wants to know. This unfortunately just related usually to age and hormonal changes. So as the man gets older It's just kind of one of those things. Kind of like women go through menopause, men go through prostate getting bigger. Huh? Yeah. And yeah, again, the issue with this is just as the prostate grows, it blocks off the urethra. So that's the issue. It's not, it's not a worry for cancer. It's just that it makes it difficult to pee. So this typically happens in men around 50 years old or so. They'll start noticing just difficulty starting urination, like having to like push harder, to kind of get the stream going. The stream might be weaker than usual. You know how you can some people can like control like the force of the urine. Not being able to empty the bladder completely is pretty common, like feeling there's still like urine in there, but you can't get it out. So that's what that is. And then what's nocturia? Anybody know nocturia? Kind of. It's got nocturnal in there, right? So you do have trouble sleeping because of this. Nocturia is having to pee a lot in the night, right? So nocturnal, people that stay up late. So that's what that is. Diagnosis-wise, this will be Makai's favorite. It's a digital rectal examination.
What?
So they have you bend over the table, insert a finger. They can feel the prostate that way.
Nah.
Yep.
No.
You have to do it.
Yeah, so they can feel if the prostate is growing larger from that digital rectal examination. They just slip in a gloved finger and feel it. They can see if it's big. They can also do a PSA. Have you heard of a PSA before? PSA. What? I can't hear you.
What did you say?
Public service announcement.
Oh, okay.
Oh,
Not that kind of PSA. That's true.
That's why you whispering.
Not a public service announcement. It stands for prostate-specific antigen. So if anyone has like a enlarged prostate, they don't know if it's benign or if it's cancerous, right? Just by the fact that it's big, right? Because there is prostate cancer as well, right? So if there is any like evidence that the prostate is enlarged, they're going to do a PSA, right? And that the PSA doesn't diagnose BPH, but it diagnoses prostate cancer. Okay, so if you have a really high PSA, that indicates that it's probably prostate cancer. If it's not, if it's low, then it's like, okay, well then this is just benign growth. Okay, so most men get PSA levels drawn as they get older. So treatment-wise, there's several options. We talked about this medication in urinary with the kidney stones. Remember the tamsulosin, Flomax would help to increase the max flow, right, of urinating. So same kind of thing. It works on the urethra. It helps to open it, make it wider, to make it easier to pee, whether it be because you have a kidney stone or because you have a prostate issue. Either way. So that's an option. There's also medications that actually work directly on the prostate and help to shrink it. Okay, and that's dutasteride. They all end in ride. We'll talk about those at the end with the meds. Then the surgery is the TURP. TURP is a pretty common. Anybody heard of that before? My dad had this done. Basically, it's where they go in. I showed you, I think, the picture last week. They go in and like scrape out some of that extra prostate tissue, so to make a pathway in the urethra for them to pee, right? So it's called a transurethral resection of the prostate. So that means that they're having a tool go through the urethra, right? Transurethral, take out some of the cells and the tissue of the prostate to make it easier to pee. Very common. And then this is obviously a chronic condition. It usually continues to get bigger as you get older, so it's progressive. But it's pretty easily dealt with either the surgery or the medications. Any questions on that one? Here's the picture of that resection, like the TURP. They're bringing in that little tool through this is like through the urethra, right? So it goes through the tip and all the way down there, and then they pull out the tissue to make it easier to pee. That's pretty much it. All right, so we just talked about benign growth. We're going to talk about prostate cancer now. So again, there's not really any way to prevent this. Like, people just kind of get cancer, although there are risk factors that increase someone's likelihood for cancer, right? Smoking, heredity, lifestyle, kind of all the same kind of deal for all the different types of cancers. So obviously, as you get older, you're more likely to get it. diets high in animal fat, more likely to get prostate cancer. The symptoms are going to basically be the same as the BPH, like it's the same thing, like the prostate's getting bigger, okay? So there's not really a way to tell the difference just on symptoms alone. It's going to be based off of that elevated PSA. So that's going to be able to differentiate between benign and malignant, okay? Yeah, and then for treatment-wise, they're not going to do a TERP, right? Because the issue is cancer, right? It's not just that it's too big. So that would help with the peeing problem, but that doesn't help with getting rid of the cancerous prostate. All right, so they can do a radical prostatectomy. What does that mean? Yeah. Ectomy means removal, right? And then radical means the whole thing. So like with a radical mastectomy, that's removing the whole breast, right? Versus like just removing the tumor. They can also do radiation, whatever, what have you, to treat the cancer. All right, that's it for the men. We're moving on to the women now. His breathes a sigh of relief. Probably starting with one of the most common ones, endometriosis. Everybody probably heard of that before?
Yeah.
It's pretty common. Endometriosis, basically what's happening is that the inside of the uterus is called the endometrium. Okay, so endometriosis is when the tissue that's supposed to be inside the uterus somehow gets out of the uterus, and don't ask me how, I don't know. That's kind of like the million-dollar question, like how does this happen? Tissue that's supposed to be inside the uterus is outside of the uterus, like in the abdominal cavity, but it still responds to the hormones. Like, you know, like when your hormones fluctuate, that's when your body knows to like shed the lining of the uterus to have your period and everything. So that tissue that's all over wherever in the abdomen still responds hormonally, and so it's like having period symptoms and cramping like everywhere rather than just like inside the uterus. Okay, so this can cause some problems. There's like swelling, inflammation, bleeding, and scar tissue kind of building up. Some people have really severe cases where it's like they open you up and like the whole entire abdominal cavity is like completely messed up. Other people have a less severe case. If it's really bad, people can have issues with fertility, having issues like getting pregnant. But most people notice that they start having like really bad period symptoms. So dysmenorrhea, dys means what again?
Pain.
Good job, pain. So dysmenorrhea is just, this just means painful periods, okay? Dyspareunia is pain with sex, so painful periods, painful sex, painful defecation, that's having a bowel movement, and sometimes infertility. So all of these kind of are like the main symptoms of endometriosis, and sometimes people don't realize they have it because unfortunately people like period cramps and pain is kind of a common thing even with people that don't have endometriosis, but it's hard to know like what's normal when you're like only experience your own body, right? Like I don't know what someone else's period cramps feel like, I only know what mine feel like, right? So it's hard to know, is what I'm experiencing abnormal? Because everyone talks about having period cramps, but are mine worse than somebody else's, you know? And a lot of times someone goes to the doctor and they get blown off because it's like, oh, well, you know, period cramps are normal, take an ibuprofen, right? And then they don't get it treated, they don't know, okay? So that's why, like, people don't necessarily know that they have it or haven't treated it because they didn't know. How do they diagnose this? Well, they would do a pelvic exam, they can do ultrasound, laparoscopy, that's like a camera, right? They can see all of that tissue everywhere. One of my close friends, you know, she was one of those that she didn't know she had endometriosis. She just thought that she had rough periods. And then when she got married and tried to have a baby, they were having a lot of hard time with infertility. And then finally got diagnosed with like really, really severe endometriosis, which was really tough. There's not really a cure for this, unfortunately. You can, a lot of times people use like hormonal treatments, like since the issue is that the tissue is responding to hormones, right? Like putting on like, sometimes some kinds of birth control can help with endometriosis symptoms, right? Because you're kind of interrupting the hormones, if that makes sense. They can do surgery to try and remove some of that tissue. But if it's like really, really bad, they really can't do too much. They might have to do what's called a hysterectomy. Anybody know what hysterectomy is? What is it?
When they take out your
The uterus, yeah. So
Yeah,
uterus is a hysterectomy. If they take out the ovaries as well, that's the salpingo-oophorectomy. Okay, so it's kind of a long word there.
Take them all.
Sometimes they can just take just the uterus and they leave the ovaries. If they can do that, they will, because the ovaries are what like secrete the hormones, right? So if you take out the ovaries, now someone's gonna like be kind of forced into menopause essentially early.
That's
So
what happens to me.
that's what happened to you. Yeah. So a lot of people, if they have their ovaries taken out, they have to be taking like hormone replacement, right? Because the ovaries are what give you the hormones, right? And hormones are important not just for having babies, but for like lots of things. Right, so if they can leave the ovaries, they will. If they can't, then they'll have to take those out and maybe put you on like hormone replacement therapy. Any questions on this one? Any personal anecdotes you want to share? All right, here's kind of a picture, an image of what that might look like. Like this tissue that's supposed to be inside the uterus is like all throughout. Okay, it's responding to the hormones. So depending on how bad it is, they can maybe remove some of it or just take out the whole thing. All right, then we have pelvic inflammatory disease. This is kind of like generic in a sense it's not caused by like one specific bacteria or like one specific thing. It's kind of like, it's kind of, for example, endometriosis can cause pelvic inflammatory disease. STIs can cause pelvic inflammatory disease. It's basically where the inflammation has just like spread all the way like into the abdomen, into the whole pelvic area. Okay, so it's not just like a specific thing. So etiology, like I said, it can be caused from infections, having more than one sexual partner, or it's just kind of like a severe advanced form of like all these other things we kind of talked about. Symptoms wise, like abdomen pain, chills and fever, and then problematic with discharge. So usually when someone has pelvic inflammatory disease, they don't have just one infection, they usually have multiple. So it's usually like not just the chlamydial infection, not just gonorrhea, but it's like several things. They might even have endometriosis. It's just kind of like the whole thing is just inflamed in there, up in there. So diagnosis wise, I mean, since it is such a widespread, the white blood cells are going to be elevated. ESR, which is an indicator of inflammation. They'll do some pelvic exams, some cultures, ultrasound, and they'll just see, yep, it's bad. And then depending on how bad it is, they might not just give oral antibiotics, but IV antibiotics. So that would be requiring being someone in the hospital, right? You know, getting the antibiotics through IV, which goes directly to the bloodstream immediately. Okay. All right. Speaking of menopause. All right, so menopause, this is also something that generally happens with age, right? Unless you had hysterectomy and salpingo-oophorectomy where they remove the ovaries as well, right? Because it artificially puts you into menopause when you don't have the ability to create estrogen anymore. Okay, so we'll talk more about all the hormone stuff when we get to the endocrine system, which isn't until next unit. But we have the pituitary gland, which regulates a lot of our hormones, the ovaries, which secrete, you know, the estrogen and everything. Without having these hormones circulating, either due to just age or, you know, having your ovaries removed, you're not going to have estrogen anymore. Estrogen is important for being able to get pregnant. Estrogen is also important for bone formation. So you probably heard we talked about osteoporosis, right? Where you have the weakening bones, you know, the little old ladies, or they kind of have like the hunched over spine that easily break their bones. Oftentimes osteoporosis and menopause go hand in hand because, like I said, the bones need estrogen to be strong. And so without the estrogen, the bones get weaker, often lead to osteoporosis. All right, so with symptoms-wise, I mean, you probably have all heard about hot flashes and moodiness and mood swings for menopause. That's related to, you know, the hormones. So your periods start becoming lighter and less frequent. So they start becoming just more irregular. So it's like, oh, you know, you'll skip a couple months, then have a period, and it's usually lighter flow until eventually it just stops altogether. Okay, but it's not considered actually being in menopause until you've not had any period at all for a whole year. Okay, so if you've had any bleeding at all, even if it was only like once every 6 months, that's not considered menopause. It's considered perimenopause. So everything like the hot flashes, all of that leading up to menopause they diagnose it specifically just based on how long it's been since you have had a period. Okay, so if you've had any period at all within the last year, it's not technically considered menopause yet. Another diagnostic they can do, and this will make more sense again when we get to the endocrine system, but they can do a blood test where they look at your hormone levels, okay, to see like what's going on. There is a hormone called FSH, which is follicle stimulating hormone. It's one of those that help control like the estrogen, okay? So if that's out of whack, then that can indicate that someone's entering into menopause. And we'll get more specific with that next unit. Treatment-wise, you can't cure or reverse menopause. It's just part of life, right? Like you can't cure or reverse puberty. It's just part of life, right? It's just something that happens. So what they're really focusing on is just treating the symptoms, okay? So like most people complain about the hot flashes. Most people don't complain about not having a period, right? Usually that's a positive. They're like, yay, that's gone. But they can do hormonal therapy to help with the hot flashes, like giving some extra estrogen to prevent those hot flashes. The one thing about estrogen though is that estrogen carries a risk for cancer. Okay, so I don't know if anybody's ever known anyone or had or taken estrogen. They usually do a lot of patient teaching about it, where they decide like, hey, like it's up to you if you want to take this, but just know that estrogen does increase your risk for breast cancer, other types of cancer, and blood clots as well. Especially if someone's a smoker, they will not give them estrogen at all. Okay, the estrogen combined with smoking, huge risk for blood clots. Okay, so they just won't do it. And then the bisphosphonates, this isn't technically for the menopause, but it's for the bone loss. We talk about this in the musculoskeletal system, so this is a repeat. The ones that end in onate, alendronate, those were for strengthening the bone. That's a review. And again, chronic and progressive. Let's go ahead and take, let's see, how much more do we have left?
A lot. Right.
Yeah.
Not too much, more than halfway. Just these. Let's take a 5-7 minute break. Get your blood flowing a little bit. Jumping jacks if you need to. Wake up, get a snack.
They're going like really fast today.
I'm trying to make sure we get done.
Yeah.
You know, because I know this one's a little bit longer. But if you need me to stop or have to ask a question, please do. I
It's
don't want.
just hard to keep up because, like,
Yeah.
I'm gonna have to go back and do like
Yeah.
That's why I record the lectures so that you can watch them and listen to them as much as you want to. But I don't want to not finish in class if we can get through.
Hey, well, you're not extra on paper. Oh.
I'm definitely an auditory listener, so I always listen to lectures over and over again, like when I was driving in the car, going on a walk, and that helped me the most, so that's why I always record them.
Don't be so mean. That whole escrow stuff, horrible, horrible stuff. Just not age. There you go. Just won't age.
Oh, boy.
While we're sitting here, was there anything that you wanted me to re-explain or go back over?
Oh, what I was gonna say earlier was, I'm gonna be here on Friday to take my biology exam, but I didn't know if you were gonna be here, or,
I won't.
I was gonna say, I could take it in the room where it's monitored, if that's something I can do.
I'll just talk to Kelly, see what she wants to do. She may be here, she may not, but I won't be here, but we'll work something out.
hard when you still live at home and like you're still going on vacations and stuff because spring breaks never line up.
Oh
It's
yeah.
Like we I got this for like Christmas. My mom bought it for us for all of us because like we've never even been on a cruise before. And she was like, she didn't ask me obviously because it was supposed to be a surprise. And I was like, that's not my spring break. She's like, well, it's your brother's. I was like, okay. Like, guess they
Oh.
can miss one class.
That's sweet though.
Yeah,
Where are you going?
the Bahamas.
I'm going to the Bahamas in May.
Really?
I've never been on a cruise either, it's my first one too.
Which cruise line are you going on?
Oh, I don't even know, that's how I went on a cruise.
If you've never been on one before, I highly recommend bringing some Dramamine along, just in case.
Bring what?
Dramamine, it's like for motion sickness.
We have like all the kinds. We went on Amazon and bought like the patches, the stuff.
Yeah, because you
like,
just don't know. Some people get really seasick. Some people don't get it at all, but like you definitely don't want to be left without it if you are one of the people that get seasick.
I think I get seasick, but I'm.
I didn't think I would either, but like the boat, just being on the boat and constantly like swaying like this, it can get to you after several days. So better to just have some in case.
Where did you go?
Where did I go last? I think it might have been the Bahamas as well. I'm trying to remember which one I went on the last one. I just remember swimming with dolphins. I don't remember where we
That's
were.
so cool.
That was like the one thing I wanted to do. I was like, I don't care where we go, as long as I can swim with dolphins.
I can't walk high.
Were they like actually wild or?
I mean,
Too much nature.
they were
Yeah.
they were in this like outdoor
Master
kind of.
inside.
It's not really like it's not an aquarium, but it's like an outdoor facility for them. So they still had a lot of space to swim around.
When we went to Key Largo, there's like this place called like the Sea Theater or something, and they've got like this whole like river to themselves. These dolphins. And then you like keep going down. There's the sharks, and then keep going down.
It makes me sad when dolphins are like cooped up in a small enclosure because they're meant to be like, you know, swimming around, doing flips, exploring.
Yeah.
So I think it's more humane when they have like these outdoor areas where they have like a whole lake or something to themselves, you know.
Yeah, it was really cool to see. They did like a whole dolphin show and stuff. This girl literally rode one like a surfboard.
Yeah.
It was so crazy. It was my first time seeing anything like that, so I was like,
I really love the dolphins. They're like water dogs.
yeah.
They're very friendly. They love humans. So. All right. And please, if I'm going quickly, you know, and you want me to restate something or slow down or repeat something a different way, just say so. But I don't know if you guys don't say so. I just assume you guys are good, okay? I just don't want to, you know, not finish and then have to have you guys wait on me to post another lecture because that's annoying and you have to mess up your whole schedule. So, all right. Continuing on. Next we have cervical cancer. So tying this back to what we talked about earlier with HPV, remember those vaccine helps to prevent the HPV from being transmitted, which is a cause of cervical cancer. Okay, so there are cancerous forms of HPV and non-cancerous forms. That's what oncogenic means. Oncogenic means cancerous or cancer causing. So if you're exposed to one of the more cancerous types of HPV, you're likely to get cervical cancer. And then again, also, the earlier you engage in sexual activity, like the younger you are, the more likely you are to get cervical cancer as well, just because the body isn't able to launch as good of an immune response when someone's like 12 or 13 versus like when they're 20 or 21 type of thing. Okay. So symptoms, cervical cancer, watery, bloody, or purulent. Again, that means pus, foul-smelling discharge. Bleeding between periods, right? Bleeding between periods is generally never a good sign. It usually means something's wrong. Maybe bleeding during sex or bleeding after menopause. So that's another thing. After someone has like officially gone through menopause and they've like had stopped bleeding, you know, for over a year, any bleeding that occurs again is generally worrisome because you should be done. So diagnostic-wise, this is why people get pap smears, okay? You have to get your pap smears every, couple years. That's what they're looking for. They're doing taking a swab and swiping the cervix they're looking for the strands for cervical cancer. You have a question?
Yeah, when somebody doesn't, when you have had a hysterectomy, is it still required to get
Yeah, I was
a
gonna ask.
pap smear?
Do you still have a cervix?
Yeah, you still have to do it.
Yeah.
Oh, cervix.
You
I was gonna
have to.
ask, if you have like, if you get all that taken out, can you still get like the STI?
If you have what taken out?
Like your uterus and stuff?
Yeah, I mean, because it's mostly affects in the vaginal area, right?
Oh,
Yeah, so it's like, it,
Oh,
you still have a cervix, you still have a vagina, you
Yeah.
still get STIs, so.
wow.
Yeah.
Yeah, 'cause I got my tubes removed. I mean, but I
Already?
still have to. Huh?
already?
I got 3 kids.
I mean, you won't get pregnant, but you can still get an STI, right? So-
Like, you know.
Wow, child.
Yeah.
I
I feel like wait, once you become a mom, like
I love that.
you
I know my auntie's
You gotta
been
know
on
it.
it.
I know my
She's
leg.
been- she's
I
been
know my
making
leg.
it, and it won't
All right,
work.
guys. Okay. Yeah. So that's what pap smears are for, right? You go in every 1, 2, or 3 years. Generally, every 3 years if you're low risk and everything's been normal. If you're high risk, like engaging in multiple partners or haven't been using consistent protection, or you've ever had an abnormal pap smear, they're going to want to do it every year. Okay, so it kind of just depends on your situation, but generally 1 to 3 years. And that's via colposcopy, right? Just visualizing the cervix. Now, treatment-wise, they do prevent with the HPV vaccines called Gardasil. Usually they give it around 12 to 16 years of age, somewhere in that ballpark. So some of you may have had it, some of you maybe didn't, but that's an option. Routine pap smears, which we talked about. If there are some early stages, thank you. If there are early stages of cervical cancer, they'll probably just repeat the repeat the cytology. Cytology just means looking at those cancerous cells and making sure that they're not progressing. So there's early stages and there's high grade. If someone's high grade, like very cancerous strands, like the progressive, aggressive kinds, they will either cut it out, which is the excision. They can do laser therapy to get rid of those cancer cells. They can do cryoablation, like freezing or burning it off, or radical hysterectomy to treat early invasive stages. Because sometimes it can progress from the cervix up into the uterus, right? So it doesn't just stay put; it can spread, right? If it's spread into the uterus, they can need to remove it. They can do radiation as well if the cancer has invaded into the pelvis at large. So it kind of just depends when you catch it, right? If it's early on or if it's progressed. And that, my friends, is lovely pap smear there. See, that's something you'll never have to experience, guy.
I'm good. I'm a guy.
This is a picture of what some, cancer might look like there, that cervix. All right, so now we're going to talk about some pregnancy-related problems with the reproductive system, okay? First one we got is hyperemesis. What's emesis mean? We talked about this back, I don't remember when, but we talked about it before. Might have been a digestive, actually. Emesis is vomiting. That's the medical term for vomiting. Okay, so hyperemesis, a lot of vomiting. Okay, and then gravidarum. Anytime you see gravid, that's always just referring to pregnancy. Okay, so this is just pregnancy-induced vomiting. And everyone talks about morning sickness, but this is like morning sickness on steroids. Okay, because you're literally vomiting all the time, can't keep anything down, you're losing tons of weight. And why this is happening is related to your hormone levels. Okay. So there's, elevated estrogen, and there's also something called HCG levels. This is actually what they are looking for when you do a pregnancy test, when you pee on the stick. They're checking for the presence of HCG. HCG is only present in people that are pregnant, okay? The reason being is because the placenta is what secretes that. Okay, so if there is no baby and no placenta, there will be no HCG, okay? So some people are just sensitive to that hormone. It makes them real nauseous. So not everybody gets this, fortunately. It's just some people. So this is just really, really bad morning sickness. Does not respond to over-the-counter treatments. They require prescriptions and hospitalization. It's so bad. Okay, so the reason being is dehydration is very bad for the mother, but also really bad for the baby as well. Right, there needs to be fluid, amniotic fluid in there, and if you're not able to have any fluid at all, it puts the baby at risk. loss of 10% of weight or more, so they're gonna be having them hooked up to like IV fluids and all sorts of other things. When they do a diagnosis, they're gonna look at your urine, right? And the urine is gonna be completely abnormal just because you're, so dehydrated. So osmolality we talked about in the urinary chapter. That's just how concentrated it is. So it's going to be, abnormal because of how dehydrated you are. Electrolytes are going to be imbalanced, nausea, vomiting, that sort of thing. Like I said, this is going to be something that they need to be hospitalized for, either for the duration of the pregnancy or until they can get it under control. Some people, their symptoms kind of resolve later on in the pregnancy, maybe towards the second or third trimester. Some people don't. Some people have to have the issue for the entire pregnancy. So, did she?
Lost weight, she looks so sick.
Yeah, this would be the worst thing, because I hate being nauseous.
I hate being around her when she looked like that.
Yeah.
Dang.
Eyes was sunken in, she looks sick.
Yeah.
Oh,
I'd rather personally be in pain than be nauseous. Nausea is the worst feeling to me. And the other thing that's interesting is that not every person, people have had multiple pregnancies. They might have this with one, but not with another. So it's not always the specific person that always gets it. All three? Man, I would have not had any more after one.
Yeah.
I'd be like, well, I guess we're one and done. Yeah, no, I could not. Alright, next one we got is ectopic pregnancy. This is basically where the embryo implants anywhere else other than inside the uterus where it should be. Okay, the most common is in the fallopian tube. You have the ovary, and then the egg comes down the fallopian tube, and then at some point, sperm reaches the egg and fertilizes it. Well, usually the egg keeps going and goes into the uterus and implants there. Sometimes it can implant somewhere else, and that's not good, right? So, show you a picture, this is the ovary where all the eggs are. Egg came down and decided to just implant in the fallopian tube and start growing, which you can imagine is suboptimal because the fallopian tube is not meant to house an entire baby, right? So it could rupture, breaking the fallopian tube open, having internal bleeding. It can put the mother's life at risk. It could terminate the pregnancy, sort of thing. So some risk factors for having an ectopic pregnancy is actually having pelvic infections, like PID, pelvic inflammatory disease, for example, just because it makes everything down there inflamed and irritated, so it's more likely to implant somewhere where it shouldn't. Also having IUDs. We haven't talked about them yet. Anybody know what an IUD is?
It goes in.
Not that. That is a form of birth control, but IUD is actually the one. It's like a little T-shape, little piece, sometimes metal and plastic, goes inside the uterus. How IUDs prevent pregnancy is by causing constant irritation in the lining of the uterus, right? That's how it prevents the pregnancy. So sometimes when someone has an IUD, the embryo implants somewhere else rather than in the uterus where it's inflamed and irritated. Okay, so that doesn't mean that if you have an IUD, you will have an ectopic pregnancy. It's just a risk factor. Okay. Symptoms-wise, if you have an ectopic pregnancy, usually one-sided pain, right? So depending on which ovary or which fallopian tube it is, it'll hurt on that side, right? So it's like, oh my gosh, it hurts so bad on this left side where that pregnancy is. Cramping, some bleeding. If there is lots of internal bleeding, like if the fallopian tube ruptures and you're bleeding internally, someone could go into hypovolemic shock. And we talked about shock back in the circulatory system, and where you lose a lot of blood, a lot of fluid, right? So if it's not unruptured, they're just going to terminate the pregnancy there, so it doesn't end the life of the mother and the life of the baby. If it does rupture, then you're going to have a whole other issue. You're going to be hospitalized and all that sort of thing. How they diagnose this is that they'll do, obviously a pregnancy test, and they'll see that it's positive, right? So they'll see that the high levels of HCG, which tells them that there is a placenta, there is a baby. But when they go to do the ultrasound, where they look for the baby in the uterus, they won't see one. They're like, what's going on? We see that you're pregnant, but we don't see a baby, right? So that tells them that the baby is somewhere else, not in the uterus where it should be. Does that make sense? Yes? No?
Yeah.
Okay. So one of the meds that they can give is something called methotrexate. If someone does have an ectopic pregnancy, this just causes the placenta to die, which will ultimately lead to the termination of the fetus as well. They can also do surgery if it's like too big, where it won't be able to pass through the fallopian tube. You know, like if it's too large, it won't be able to come out. They can do the surgery to get it out. And that's pretty much that. Next one is preeclampsia and eclampsia. Also pretty common condition in pregnancy. Anybody ever know anyone who had this? Yeah? I had a friend who had this as well. You know, and she was like, I don't understand, like, I'm healthy, like, I don't, you know, and it's not really something that you can prevent, so, like, a lot of women tend to have a lot of, like, guilt over things like that with, you know, if they have, like, a miscarriage or if they have any other pregnancy issues, but just, like, letting them know, like, this isn't, like, your fault, this is just something that happens to some people. Basically what's happening in preeclampsia is that the placenta doesn't have good blood flow for whatever reason, like, the placenta isn't formed properly, which, you know, isn't anyone's fault or anyone's control. So like, this is not the greatest picture, but it was just really difficult to find a picture. These are supposed to be they're called the spiral arteries that go from the mom into the placenta. You can see this one that it's really wide and it has good blood flow. Whereas over in this one, it's narrower, narrower, is that a word? More narrow? Whatever. And more like kinked up and hard to get the blood flowing. So this is preeclampsia, where like it's just the blood flow to the placenta isn't as great. Okay, so what the body does, the body, like the mom's body, they notice that the blood flow isn't great to the placenta, and they're like, hey, we need to increase blood flow to the baby because the baby needs that. So what they're going to do is like a compensation. They're going to increase the mom's blood pressure, which is going to increase the flow of the blood, right? Anybody ever had a hose and like put your thumb over the end to make the water come out faster? You know what I'm talking about? Like you kind of like block part of it. It speeds up the flow of the same kind of idea. The mom's body starts increasing their blood pressure to try and perfuse more blood to the baby. But that just becomes like a vicious cycle because like the mom's blood pressure keeps rising and rising and rising and rising, and that's why people go in. You know how they check your blood pressure every time when you go for your prenatal visits. And so when a mom's blood pressure starts getting too high, it's like an emergency because she could have a stroke, right? The mom could have a stroke, heart attack, whatever. So then they try to deliver the baby if they can early, because as soon as the baby is delivered and that placenta comes out, everything's fixed, right? The mom's body's like, oh, well, we don't need to increase our blood pressure anymore because there's no more placenta. Does that make sense? So this gets resolved with the birth of a baby. So oftentimes they will try and like put the mom on some bed rest, try to keep her blood pressure as low as possible. Like, hey, don't go do exercise or whatever, or anything else that would raise your blood pressure even more. They try to wait till the baby is like at a point where it can be delivered safely. Like I don't know exactly how many weeks, maybe 34 weeks or so, where the baby's viable. So that's what they usually do. Is they usually have like either an emergency C-section or schedule to have the baby delivered for this reason. They do notice that some risk factors for this is this isn't, again, something bad, but typically older women tend to struggle more with preeclampsia than younger women. So being older than 35, having had multiple pregnancies, or if you have any other conditions like diabetes or lupus or autoimmune. But at the point where it becomes eclampsia versus preeclampsia is when the blood pressure gets so bad that the mom has a seizure. Okay, so that's the difference between preeclampsia and eclampsia. Otherwise, it's the same thing, the increasing of the blood pressure. Once the mom has seizure symptoms, now they call it eclampsia. Okay, so that's really the only difference. Any questions about this one? I know it's kind of weird, maybe a little complicated.
Why doesn't the placenta have a good blood flow?
We don't know.
Oh.
It just happens. Like the placenta was just formed incorrectly, or like having a baby is a very complicated process, right? A lot of things can potentially go wrong. So like some babies are born with birth defects or whatever. Sometimes the placenta is just formed with not great arteries to get the blood flow. Okay. So yeah, it's a vicious cycle where the mom just keeps increasing her blood pressure to give blood to the baby to the point where now the mother is having issues because she could have a stroke or have seizures with her blood pressure being so high. Does that make sense? Okay. All right, next one is abruptio placentae is the correct medical term. You might have also just heard of it as placental abruption, is like the common term. This basically what's happening here is that the placenta disattaches from the uterus prematurely, right? That's not supposed to happen until after the baby's born. You know, like when you give birth to the baby and then, you know, X amount of time later, a few minutes later, the placenta comes out, right? If the placenta starts detaching during pregnancy, that's an emergency, right? Because now the placenta is what gives blood and oxygen to the baby, so if it starts detaching, the baby could die inside, okay? So that's what this is, complete or partial separation of the placenta from the uterus. Different risk factors, moms with high blood pressure, so obviously preeclampsia can be a risk factor for this. Trauma, so if someone got hit really, really hard while they're pregnant or like in a car accident, it can like jostle the placenta and cause it to rip off. Some infections, drug use, also having more than one baby, like multiple gestations, like if you have twins or something, it makes it harder for the uterus to hold all that, because you have two placentas instead of one, right? Because you have two babies, two placentas. All right, so the biggest symptom with this is just bright red bleeding. So a lot of bright red hemorrhage out of the vagina. That's like, okay, this is bad. There should never be bright red bleeding, because that means an active bleed. Some like darker, you know, like period-looking blood, like darker red, that can be normal. But if it's like bright red, that means that something's ripped, something's torn. Also, painful contractions. Anytime there's any of that, we go to the hospital. They diagnose it with ultrasound. They can see the placenta detaching in there. They can also look at the fetal heart, so they can like, you know, listen to the baby's heart, and if the baby starts being in distress from the lack of blood flow and the oxygen, they'll probably do an emergency C-section, depending on how bad it is, right? Sometimes only part of the placenta is coming off, not the whole thing, right? So they'll be like, okay, like, hey, the baby's only 20 weeks right now. If we do a C-section right now, baby might not make it, or might have to be in the NICU. So if it's like only partially come off, they'll probably just try to keep you like in bed rest, to try to keep it from detaching anymore. But it kind of just depends on how bad it is and how far along you are. Does that make sense?
Do
So
they normally know, like, when it detaches, can they feel it?
Who's they? The mom
Like
and the baby?
The mom.
I mean, there could be pain, yeah, because it's like it's causing a wound inside there. I mean, you'll also notice all the bright red bleeding, right? That's kind of hard to miss. But yeah, it kind of just depends how far along the baby is and how bad the detachment is and what they're going to do. If it's a very small detachment and the baby is really young, they're going to just wait it out. But if it's, you know, the baby's, you know, viable, it can survive, and it's like really bad, they'll probably just do an emergency C-section to prevent any complications. Yeah, that's pretty much that. And this is just, you know, picture. I didn't draw this. This was just something I found on Google. Here's the picture of like the placenta coming off and the bleeding from that wound. So yeah, it does sometimes, you know, hurt because it should be attached and it's getting ripped off, you know. All right. Here is some of I kind of condensed a bunch of stuff in the book into like just the slide here of different like types of contraception. You've probably heard of most of these options, but I just wanted to talk about them in class. So contraception is how to avoid getting pregnant. Okay, obviously there are sterilization options. So these are like the permanent routes, right? For men, they can get a vasectomy. And that's just where they do the little snip snip so that the sperm can't come out with ejaculation, right? So there'll be ejaculate but no sperm. So there's no chance of getting pregnant. They can reverse those sometimes, and sometimes they fail. So it's still good to have a backup plan. Then there's a tubal ligation, that's getting your tubes tied. Okay, they can. This can also sometimes be reversed as well, just like the vasectomy. They can like tie them off, and then later they decide they want to undo it. They can reattach them. So those can sometimes be reversed. Hysterectomy, that can't be reversed, right? If you take out the uterus, it's gone. Like you can't put it back in. Then there's IUDs. That's the little T, that goes inside the uterus, sits in there. They have a couple options. There's the copper one. That one lasts the longest. That's 10 years. And then there's the Mirena. Have you heard of Mirena commercials and things like that? Those usually last about 5 years. There's spermicides. Those are just like lube that you can use that kill sperm on contact. The only issue with those is that some people are really sensitive to them. It can get like irritated skin, but generally otherwise they work pretty well. Then there's barrier methods. A barrier is just anything that prevents the sperm from reaching inside the egg. Okay, so condoms are the most commonly used barrier methods. They also have what's called diaphragms and cervical caps. Cervical cap is basically just like literally a hat that sits on top of the cervix to prevent anything from getting inside of it. Then there's the fertility awareness calendar method. This is just basically avoiding having sex when you're ovulating. This just requires a lot of accurate, record keeping and being aware of your body. Not obviously the most effective, right? Because you can still get pregnant anytime during your cycle. Ovulation is just the most likely when you're the most fertile, right? So this doesn't always work, but some people have religious reasons or personal reasons why they don't want to use any type of birth control, so they do that. Okay. There's also what's called lactational amenorrhea. This is the idea of when people give birth and they are breastfeeding and it keeps their period from returning, and they, the idea is that if your period hasn't returned yet, you can't get pregnant. This works sometimes.
Sometimes.
It doesn't work all the time. And not everyone who breastfeeds will have a delayed period. For example, I did exclusively breastfeeding for a year. I got my period back in 8 weeks. I was very sad.
Oh my
I was excited to not have a period for a while, and I was very discouraged. I was like, dang it.
Yeah.
So that doesn't work for everyone. And then sometimes you can get pregnant right before your period would have come back, and then that's how you get the Irish twins, right? You're like, that's you.
That's me. Yeah, me too.
Yeah, so obviously sterilization is the most effective and most permanent, and these two are not super effective or trustworthy, but it's still methods that people use. These are hormonal options. So barrier methods, these don't involve hormones, right? These don't involve hormones. These ones do. So there's implants. That's the one that you're talking about, Marissa.
I hated that.
You hated that one? Is it the Nexplanon?
Yeah.
Did you have that?
Yeah.
What did you hate about it?
Oh, I was just constantly just flowing.
Oh, okay. So it just it was not good for you.
No.
Yeah, the issue with hormonal options is that everyone responds differently, right? So some people have no problems. Other people have terrible bleeding, terrible cramping, migraines. I had a friend who had the Nexplanon implant and she just blew up, as far as gaining tons of weight because of hormones. So hormones are kind of a risk just because you just never know.
I had a friend that we pretty much got it in the same time. She's perfectly fine.
Yeah, so it's kind of unfair. You just never really know. The other thing with hormonal options is that it does involve estrogen, and if you're intaking extra estrogen, that increases your risk for breast cancer, right? So, and then again, people that are smokers, they're not going to want them to be on hormonal options of birth control because of the risk for clots. So that limits them to maybe an IUD or condoms or things like that. Okay. Yeah, so the implants, that's the one that it's a little tiny rod that gets inserted into your arm and it just constantly releases some hormones until it's needs to be replaced every 3 years. There's the injections. Everybody heard of the depot shot? Mm-hmm. That's literally you get every 3 months. They inject that, prevents pregnancy. Same issues with the other ones as far as gaining weight, having mood swings, having period issues. So you just never know. Birth control pills, those are probably the most commonly used, commonly known.
So those are the best.
They are the best.
Yeah. Those, the only issue with those is that you have to do them every day, regularly. If you miss one,
It's over.
it's over. Yeah, so people that aren't super great at that, the other options might be better, that you don't have to think about it, you don't have to remember, you don't, if you lose it or get behind your prescription, so Kind of just depends on what you need. There's also patches that you can wear, like a little sticker, that can do the same thing. You replace them, I think, every week. And it does the same thing, releases hormones through the skin.
My sister has that.
Yeah. So it kind of just depends, what you know about yourself. Like, hey, like I don't want hormones, or I do, or I'm really bad at remembering to take pills or whatever. So it kind of just depends. And then there's like a vaginal ring. It's actually kind of similar to the idea of an implant, but it's like something you just insert into the vagina and it releases hormones as well.
I've never heard of that.
Yeah, they're not as commonly known as the other ones.
That's what I use.
The ring. Do you want to share anything about it since people have never heard of it?
I know, just like,
No, it's just. It's
yeah.
yeah. It's pretty straightforward. I mean, it works good.
Yeah, so there's different options, people, lots of whatever floats your boat. Then we have the emergency contraception. So this is not something you do every day. This is like, oh shoot, I think I might be pregnant, or like there's a chance that I might be pregnant. Plan B is the most commonly known one, right? You take this the morning after pill type of thing. It usually works up to, think,
48 hours.
48 or was it
46
72?
or 48.
Huh? I don't.
It's
I
not
don't
illegal
know.
now because it's still at Walgreens.
Oh my God.
I'm not saying I've
I
used
know
it.
that.
I've
Like,
just been
it's
in
there.
Walgreens.
I know, yeah. But I just saw
Oh, I
that
know
too.
that.
Someone in Georgia.
But wasn't that they were like, I think it's all, it was like, she was like months
This is the first case since.
Plan B only works up to like, I don't remember, it was 48 or 72 hours. If you're already pregnant, it won't do anything. So it's not the same thing as an abortion pill,
oh,
because it won't do anything.
That is illegal.
If fertilization has already occurred, Plan B won't do anything. It's like, well, too bad. What it does, if because sperm takes several days, sitting in the uterus to like get to the egg. So if up until fertilization has happened, the Plan B will work. Okay. But yeah, it doesn't actually end the pregnancy. It doesn't work that way. That wouldn't be available like over the counter. Okay. Another option of emergency contraception is getting an IUD placed. So if you get an IUD placed within 5 days of unprotected sex before fertilization has happened, it will prevent a pregnancy. So, all right. Any questions about those?
So many options.
Yeah. Notice that most of them are all towards women, except for that.
I heard that they were trying to like make a men's like thing.
Yeah, that'd be
That they were
nice.
trying to get approved through the FDA or something.
Yeah.
So I looked into it.
Basically, the only thing that men can use on here is they can get a vasectomy. I mean, both partners can use spermicide, and then they have male and female condoms. So, but female condoms are a lot more, like kind of more complicated to use. Kind
Don't
of.
you have to get fitted for those or something?
I don't know.
I don't know.
All right, moving on to breast conditions, and then that should be our last topic. Okay. First one is fibrocystic breast. This is pretty common. Everybody have like cysts in their breast, like a lump that like kind of hurts that comes with their period. Usually it's related to like hormonal changes. So they're like, it really hurts when I'm on my period or whatever. So this is not cancerous or anything. This is just a hormonal thing. They're tender. They have pain. Usually worse during PMS. You can feel the lumps. They can be on one side or both sides. People might be freaked out thinking, oh my gosh, this is cancer. But usually breast cancer does not hurt, okay? And it doesn't come and go with your period type of thing. So that's one way to tell the difference. Treatment-wise, I mean, it's just taking some pain medicine to make it better. Sometimes birth control can help because it's hormonal, so it's calming down the hormones. So a lot of people take birth control not just for preventing pregnancy, but sometimes to help with acne, or sometimes to help with like really bad periods that can help too, or these painful cysts. So hormones can help lots of people, but also can cause problems as well. So you kind of just have to see what's in your best interest. They can also do what's called fluid aspiration. So if the cyst is like really big, they can put a needle in there and drain it. That's what fluid aspiration is. They are benign, so there's no risk of cancer or anything, but they do tend to recur. So like people who are prone to having these typically, have flare-ups of this, usually pretty commonly. And this is just kind of an example of what a cyst might look like. Just they pop up with PMSing or whatever, and then they tend to go away. All right, then we have mastitis. Itis meaning inflammation, mast referring to the breast, hence like mastectomy, right, removal of the breast. This is usually caused by strep or staph infection. What happens is the bacteria get in through the nipple, get into the milk ducts, usually from like breastfeeding, like something maybe like in the saliva or gets passed there somehow. And what happens is that the inflammation of the ducts, like they're not able to, like the milk isn't able to get out since everything is inflamed, right? So that pain is like the pressure of the milk, okay? You're nodding your head.
It's the worst.
Have you had it?
It's the worst pain ever.
Yeah, I had an occluded duct, not from mastitis, but just from blockage, and I was just like, ow, this hurts so bad.
And then trying to squeeze it out and like do it, it's the worst.
Yeah, it does not feel good. So obviously pain, redness, heat, might feel really tough, like there's rocks under the skin. If it gets really bad, it literally feels like there's like some pebbles under there. The lymph nodes could get involved, since this is due to an infection. There might be some discharge, fever, whatever. Diagnostic is usually pretty easy. They can pretty much just look at it, and they might be able to do a swab of some of the discharge. But they're just gonna, tell you to take some antibiotics, put some heat on it, and kind of just hope and pray for the best, This is an acute thing, so it usually resolves pretty quickly. Some people tend to have it multiple times, but it's not life-threatening or anything. This is what a severe case can look like very extremely red and swollen. You can imagine how painful that might be. Not all cases look, like this, but it's pretty painful. All right, next one is breast cancer. Risk factors for this, obviously heredity, so it tends to go in families. So if you have an aunt or a grandma that had breast cancer, there's often a genetic component. So they have actually genetic screening that you can do to see if you're a carrier, if you're at risk. Was it Angelina Jolie that got both of them removed just because it was in
that BRCA gene?
Yeah. The BRCA, there's a gene that can get passed down, and I think it was her, right?
Yes.
She was I don't want to have any risk at all, so just chop them off.
The girl, her name's Misty. She has the BRCA gene, and she got her food, she got it all removed and stuff, and then she ended up getting pancreatic cancer anyway.
That sucks. Yeah, you can't get that removed because you need that. Yeah, that sucks. So you can do that. Obviously, a lot of people don't want to have their breast removed until they have to. But another risk factor, as I've mentioned a couple times now, is prolonged exposure to estrogen, right? So if you're on hormone therapy, that's going to increase your risk. Hormonal birth controls, that increases your risk. So it's kind of lifetime exposure to estrogen, right? So it's not like taking it once is going to give you breast cancer, but over a period of time. So if you also had a young age when you started your period as well, that's also adding several years of exposure to estrogen. So someone who had their period at 8 years old is going to be more at risk than someone who had their period starting at 15 years old. Okay, does that make sense? Because they had longer exposure to estrogen throughout their life. And also if you were older when you got menopause. So if you got menopause at 40, no more estrogen. But if you got menopause when you're 65, that's a lot more years of estrogen, okay? So that's really that. Okay, so breast cancer symptoms, you will note, you feel a lump, maybe some swelling. It typically does not hurt though. It's not painful like a cyst, right? They're usually pretty painless. There is something called peau d'orange. That's actually a French word. Peau means skin, and d'orange means of orange. So it's skin that looks like an orange, and that's this is the breast. It kind of looks like an orange, doesn't it? The dimples or whatever, kind of look like an orange peel. So breasts that look like an orange peel, that's a symptom of potential skin cancer. What else? Sometimes the nipple can be retracted or ulcerated, whatever. Diagnosis wise, you know, we do the mammograms, right? So those typically, people don't usually get those until I think about age 40. Don't quote me on that, but I think it's around age 40. Unless you have like a strong family history, they might start you earlier. Or if you've noticed a lump, you know, and you're younger, they might send you for a mammogram just to go check it out. But generally, the routine ones start in your 40s or so.
My coworker doesn't believe in mammograms.
Oh,
I mean, she doesn't.
She's a nurse.
Yeah, I know
Said,
people
okay.
that don't believe in mammograms too.
so
We,
stupid.
medical freedom in America. You can do what you want.
Yeah.
They think it's that's what's giving them cancer.
Huh?
They think the mammograms are the one that's giving them cancer.
Well, I mean, radiation does increase your risk for cancer. So I mean, they're not like totally wrong.
Yeah.
You know, I think it's just, you know, weighing the risks and the benefits. You know, if you have no family history at all, never had anybody in your family with cancer, maybe you can probably get away with not having them. But if you're high risk, then it's probably better to get them than not get them. You know, so. If anyone comes in with any suspicious lump, they're gonna, you know, maybe do a biopsy. They can tell you, oh no, this is just a cyst, don't worry, or like, oh, this is actually breast cancer. Treatment wise, it kind of just depends on how bad it is, right? So that's all cancers. They can remove the tumor. That would be a lumpectomy if it's, you know, really small. If it's the whole breast, that's a mastectomy. Chemo, radiation, same thing with all cancers. And I don't know why I put all this here. I think this was all in the book. So we talked about this already. Radical is the whole thing. Partial, obviously part of it. Lumpectomy is just the tumor. And then the removal of the lymph nodes. So some people have it spread, you know, pretty far, so they have to get the lymph nodes removed. This generally is what causes like the most problems. You know, people have like swelling issues. I know this one lady who had a radical mastectomy with the lymph nodes also, and like she has terrible lymph. Remember when I showed you a picture of like the lymphedema back in, oh gosh, was that circulatory? Or like the swollen, like her whole arm is like super like swollen because like the lymph drainage, she doesn't have the lymph nodes there, so it's really bad. So that's not fun. I showed you that already. Okay, and we're wrapping up here. So here's the meds that relate to reproductive. Talked about these already. The PDE5 inhibitors, these are for the erectile dysfunction, Viagra, Cialis. They end in fill, right? You can think like fill the penis with blood. That's how I remember it. Whatever helps you remember it's great. Meds for BPH, they have meds to reduce the actual size of the prostate. It's the dutasteride, finasteride, they both end in ride. Ones to increase the urine flow, and again, this isn't just for, you know, just for BPH, it can also be for the kidney stones. Remember to increase the urine. They end in osin, tamsulosin, silodosin, doxazosin, alphazosin. Birth control pills, we've talked about those. These contain estrogen and progestin, which is just important when we talk about the lifetime exposure to estrogen and risk for cancer, right? Meds for menopause, we talked about bisphosphonates in musculoskeletal. These are the ones for osteoporosis that strengthen the bone. These end in the onate, like the alendronate. And then estrogen hormone replacement therapy, and that helps with like the hot flashes and the mood swings. People that have also had, you know, their uterus and ovaries removed as well might also want to benefit from going on hormone replacement therapy since they're not getting any anymore. And then antibiotics. We talked about several of those for bacterial sexually transmitted infections, and just for your reference, I put all the classes here again. They were on the integumentary, so it should be review. These first bullet points are the different classes of antibiotics and what they end in. So like penicillins all end in cillin, like amoxicillin. Cephalosporins all start with ceph, like ceftriaxone, cephalexin. The macrolides end in mycins, like erythromycin, azithromycin. Quinolones, they have fluoxetine in their name, ciprofloxacin, levofloxacin, and so forth. So there's so many antibiotics. This is like as condensed as I could possibly make it, just giving like one or two examples. But that's pretty much it for reproductive. Finished on time, yay. Any questions about anything? All right. Well, you know what to do. I'll go back and make the thing visible. Give me 1 second. Reproductive quiz. Make visible. You should be able to find it now.